Here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Dr. Mahesh Goenka, to start this session. Thank you, and over to you, sir.
Thank you, Mr. Singh, and good evening, everybody. So we are with another session of NBE Super Specialty Gastroenterology online class. And we are today in Bombay Hospital and Medical Institute, one of the premium institutes from Mumbai. And we would be having a discussion, both the presentation related to ulcerative colitis and extraintestinal manifestation. So today we have Dr. Vaibhav Somani as the resource person in the faculty, and he would moderate the two presentations. Of course, I'm there. Before we start with the presentation, let me tell you that one point which I've noted is that some repetition of the topics which is taking place. And this is because of possibly you not having an information about what have been discussed in the recent past. So what we are doing in the next 1 or 2 days is to collect all make a sheet of everything which has been discussed in the last few months, and so that we have new topics and we would have some suggestion and discussion between my office and the people who are presenting, so that we have new topics being covered. With that, I will pass on to Dr. Somani to take us through this meeting. You need to unmute yourself.
Sir, I'm thankful for this opportunity and very happy to be here amongst all of you. So we'll start with the case first. It is a case of ulcerative colitis with extraintestinal manifestations, which will be presented by our third year DNB resident, Dr. Amin Siddiqui. Dr. Amin, if you can start.
Yes, sir. Good evening, teachers and colleagues. Today I'm presenting a case of ulcerative colitis with.
Are you sitting in a public place, or you can remove your mask? I don't know whether, depends on where you are sitting. Right.
Yes, sir. Sorry, sir. A 22-year-old female patient, Christian by religion, presented with chief complaints of diarrhea since 6 months and poor oral intake since 6 months. She was relatively asymptomatic 6 months back. Then she started having diarrhea 4 to 6 times a day, semi-solid to liquid in consistency, yellowish in color, small in quantity and non-foul smelling. History of blood admixed with stools occasionally. These episodes have increased in past 1 month. Diarrhea is typically postprandial and not associated with any specific food type, and it even continued on fasting. It was associated with urgency and crampy abdominal pain in hypogastric region, which gets relieved after defecation. Patient also gives history of nocturnal diarrhea since past 15 to 20 days. There's a history of poor oral intake since past 6 months. The diet has decreased from 3 chapatis and 1 bowl of vegetable to 1.5 chapatis in entire day. It has led to an unintentional weight loss of 8 kilograms in past 6 months. It is associated with easy fatigability. Patient is unable to perform her daily course since past 10-15 days. For above complaints, she was taking medications from a family physician for about 4 to 5 months, but there was no relief. These medications included antibiotics and multivitamins. No history of fever, joint pain, jaundice, or pruritus. No history of dysphagia, vomiting. No history of cough. No history of hematemesis, melena, perianal pain, fecal incontinence. No history of food intolerance or allergy. Past history: patient had a scoliosis for which she underwent a spine surgery at the age of 14 years. Post-op recovery was uneventful. No history of the above mentioned illnesses in the past. She was born by normal vaginal delivery out of a non-consanguineous marriage. She is a single child to her parents. Perinatal period was uneventful. She has short stature for her age, which she was told to be because of scoliosis. Personal history: there is no intravenous or oral drug or substance addiction. No history of unprotected sexual intercourse. Patient achieved menarche at 14 years of age, and since past 4 months, she is having polymenorrhea with menorrhagia, menstrual cycles of 18 days with 8 to 10 days of blood flow. Her family history is insignificant. So to summarize, my patient is a 22-year-old female patient with history of diarrhea since 6 months, with small in quantity, admixed with blood, with crampy abdominal pain, which gets relieved by defecation, along with poor oral intake and weight loss of 8 kgs in last 6 months and easy fatigability, is most likely a case of large bowel type of diarrhea, could be inflammatory or infective, with micronutrient deficiency. I would like to give differential diagnosis of inflammatory bowel disease, tuberculosis of intestine, most likely colon. I would like to rule out immunocompromised state and associated opportunistic infection, infective colitis, most likely amoebic, or malignancy, adenocarcinoma of colon.
I can ask you, Dr. Somani, can I interrupt him a little bit?
Yes, sir.
So can you go back to your list of possibilities? That's
Yes.
all right. List of possibilities. Next slide. So you have mentioned fourth possibility is amoebic colitis.
Yes,
So do you think this history fits into amoebic colitis of 6 months duration?
Sir, it is very less likely for amoebic colitis to go on for 6 months. However, since endemic in India, I have kept it as a distant possibility, sir.
So what are the infections which can have more prolonged course rather than usually acute self-limiting colitis? Most of the infective colitis are usually self-limiting colitis. What are the colitis which can go beyond a couple of days or maybe into weeks or months?
Sir, in immunocompetent patients, this could be tuberculosis, this could be amoebic colitis, this could be Campylobacter, this could be some viral infections. Then, sir, in immunocompetent,
Like
sir, cytomegalovirus.
in an immunocompetent individual?
Sir, rotavirus,
Rotavirus in the age of, what's the age of the patient?
22 years old, sir.
22 years, rotavirus, if it's immunocompetent, would be very, very unusual. It's a disease of infancy.
Yes, sir.
So you did talk about, what about Yersinia?
Yersinia, yes, sir. Yersinia can cause prolonged.
So Yersinia and Campylobacter are two infections other than tuberculosis, which are known to run for weeks rather than days.
Yes, sir.
When we are talking immunocompetent individuals, immunocompromised individuals, we know that many possibilities can be considered.
Yes, sir.
So when you say immunocompromised state, are you talking of HIV?
HIV, yes, sir.
Okay. So what are the associated opportunistic infections when you talk about HIV?
Sir, which can lead to diarrhea are Cryptosporidium, Cytoisospora, Cyclospora, Isospora, and sir, Entamoeba.
So you
Entamoeba
can differentiate about those which will have colonic involvement and those which will have a small bowel involvement, because this patient obviously have possibly fresh bleeding per rectum, so it's more likely that there is a disease in the large intestine.
Large intestine, yes, sir.
Fine. So the first possibility is inflammatory bowel disease. What form of inflammatory bowel disease are we talking about?
Sir, this patient is having a large bowel diarrhea symptoms with crampy abdominal pain and history of urgency, sir. So most likely it would be ulcerative colitis. Sir.
So how common is pain abdomen in ulcerative colitis?
Sir, in ulcerative colitis, it is less as compared to Crohn's disease. It is seen in roughly 40 to 45% of patients.
So what in ulcerative colitis can cause pain?
Sir, in ulcerative colitis, the pain could be because of movement of distension of lumen because of oncoming feces. Then it could be.
I didn't get it. Can you repeat that?
So distension of the intestine due to feces can cause pain. Then
You mean, are you talking of obstruction? Are you talking of obstruction?
no, sir. The feces, the oncoming feces, which can distend the abdomen, which can distend the lumen, can cause pain, sir.
Any other cause? I mean, sir is trying to lead you somewhere.
Sir, superadded infection like Clostridium difficile can cause pain in ulcerative colitis. Or
So ulcerative colitis with this pain, then you have to think of several possibilities, including megacolon,
megacolon, yes, sir.
benign strictures,
Benign strictures.
or malignancies, in addition to superimposed infections you're talking about.
Yes.
All right. So you don't think it's Crohn's disease?
Sir, it's less likely to be Crohn's disease.
Why? Why?
Sir, her symptoms like fresh bleed admixed with stools, with urgency, with.
But can there be a rectal involvement in Crohn's disease?
What is Crohn's colitis? Can it present like this?
Yes, sir, Crohn's colitis can present like this.
I think if somebody has abdominal pain and you're thinking of inflammatory bowel disease, you can't just say it's ulcerative colitis. You have to think of Crohn's disease also. And as we know, about 1/3 of the patients with Crohn's disease can have large bowel involvement predominantly. And we know that in about 50% of the patient with colonic involvement of Crohn's, there can be rectal involvement. So it is, while present of bleeding per rectum in an inflammatory bowel disease goes more in favor of ulcerative colitis than in Crohn's disease. But if there is a pain which is significant, then I would not get away saying that it's all ulcerative colitis, and I would also keep a possibility of Crohn's disease.
Yes, sir.
One last question here.
Yes.
What is you told about opportunistic infection? What is the most common opportunistic infection you see in these patients? Especially those who are hospitalized?
Sir, in the ulcerative colitis patients?
Yes.
Sir, Clostridium difficile.
What about CMV?
Sir, Clostridium difficile is more common as compared to CMV, sir. 14 to 16% patient with flare have Clostridium difficile.
What is the frequency of CMV?
Sir, I'm not sure, sir, but I think 8 to.
So I think both the possibilities are there, and the data on CMV complicating ulcerative colitis is highly variable from India.
Yes.
All right. I'm looking for the chat box. Is there any other possibility any of the DNB students is thinking about, other than the few which has been mentioned on this chart? All right, while we're waiting for others to respond, we can go to the clinical presentation.
Yes, sir.
See, one more thing I must tell you, that you are going to be appearing for exam very soon, isn't it?
Yes, sir.
So in your first 2 or 3 slides, look back after your presentation is over. You have to either use past tense or you have to use present tense. You have mixed your present tense with the past tense many places. So
Yes,
just look at your slides. You should be very clear as to what is happening and what has already happened, so
Sure.
that your presentation should not be confusing. Sometimes you have talked about past tense and sometimes you have talked about present tense. Carry on.
Thank
It's
you.
a minor point, but should be taken care of.
Thank you, sir. Yes, surely, sir. Patient is conscious, alert, cooperative.
There is a possibility which has come, Dr. Somani, on the chat box. Can it be ischemic colitis?
Someone has prompted that is it possible to have GI vasculitis with these symptoms?
Sir, for 6 months history, less likely, sir.
What are the points against GI vasculitis in this patient?
Sir, it will have the patient will be more hemodynamically unstable in this patient, and the diarrhea with there will be a large quantity of hematophagia as compared to the other possibilities, sir.
Not necessary. What age group is common in GI vasculitis?
Sir, it is seen in the elderly population, sir. Fifth or sixth decade.
So when you talk of ischemic bowel, it's a very broad term which we are talking about. It can be arterial thrombosis, it can be venous thrombosis, it can be non-occlusive ischemia. So I think we are talking a very broad spectrum. But then a presentation for 6 months would be distinctly uncommon. If the same patient would have presented with a short history with bleeding per rectum and pain abdomen, that would come in a differential diagnosis. But for 6 months presentation, I think it is distinctly unlikely to be having that. And HIV, you have already talked about. Somebody has suggested HIV, and somebody has issue about 8 kg weight loss in ulcerative colitis. So is this a very important point?
Yes, sir. Sir, it was associated with anorexia, sir. So, there is one more extraintestinal manifestation coming in, sir, which we could not pick up on history.
We will come back to this later. Carry on.
Patient is conscious, alert, cooperative, and comfortable in supine position. Her weight is 35 kg and height is 150 centimeters. Body mass index of 15.9 kg per meter square. There is a loss of supraclavicular pad of fat, wasting of thinner muscles. Pulse rate is 100 per minute. Low volume, regular. All peripheral pulses are felt. 90 by 70 mm Hg of BP and respiratory is 20 per minute. No, there was no paler icterus, clubbing cyanosis and edema of feet. There was no lymphadenopathy. Skin is dry, no hyper or hypopigmented spots, scratch mark or ulcers over the body. There's no alopecia. Nails show platinikia. Eyes and conjunctiva are normal. Angular stomatitis is noted. Rest of the oral cavity is normal. Axillary hairs are present. Breast tissue is atrophied. Nipple areola complex is normal. No residual scoliosis as visible, sir. Scar marks of previous surgery is noted on the back. There's no limb deformity, sir. Systemic examination. On inspection, the shape of abdomen is scaphoid. Overlying skin is normal with no scar mark, dilated veins, pigmented spot or discharging sinus. Umbilicus is inverted. No localized or generalized swelling. On palpation, there is no guarding or rigidity on superficial palpation. Liver is palpable in right hypochondriac region along the midclavicular line, approximately 3 cm below the costal margin. Liver is soft, non-tender, margins are regular, anterior surface is smooth. Movement with respiration is present. There is no pulsations felt. Spleen is not palpable. No other mass is felt. For rectal examination, patient did not give consent for rectal examination. Tympanitic note in all quadrants of abdomen. Upper border liver dullness is present in fifth intercostal space. The liver span is 12 centimeters. Vowel sounds are audible in all quadrants. In respiratory system examination, movement of chest are reduced on the left side. Vesicular breathe sounds are heard in all areas in both the sides. Cardiovascular and central nervous system examination are within normal. So at the end of examination, my differential diagnosis remains the same, but there is an important finding in the systemic examination, that is hepatomegaly. Hepatomegaly with inflammatory bowel disease can come in several possibilities, like primary sclerosing cholangitis, non-alcoholic fatty liver disease in these patients. If it is tuberculosis of intestine, then tubercular infiltration can cause hepatomegaly. Infective colitis, especially with amoeba, it is highly unlikely because the patient will have tenderness and there will be fever. In malignancy, it could be because of metastasis.
So why your immune compromise has disappeared from the list?
Sir, there was no IV drug abuse history or substance abuse history. There was no history of unprotected sexual intercourse. And on asking leading questions to the mother at the time of her delivery, her seromarkers was done, which were negatives.
No. See, come back to this. You had all these when you had clinical history taking.
Yes.
So after history taking, you kept that as a possibility. And after examination, that possibility has disappeared. So what happened between history taking and examination that your possibility of immunocompromised individual with opportunistic infection has disappeared? What clue in the clinical examination has made you make it disappear from your differential diagnosis? All these what you mentioned just now are from the history, but at the end of the history, you had that as a differential diagnosis.
Yes, sir.
Why? Did you expect something on the clinical examination if the patient would have HIV?
Sir, she would have a non-healing ulcer or on the body, sir. But yeah, I would still have kept, sir. That's my mistake, sir. I would still have kept immunocompromised patient as
So
a
I think from the examination, when you appear for the examination, It's
Yes.
always good to retract rather than giving an explanation all the time. The explanation may not be correct. So there's no harm in retracting and saying that yes, it remains in the possibility.
Yes,
So
sir.
you did talk about Platonychia. Did I get
Yes.
it right?
Yes.
So what does that mean?
So there are flat nails in this patient, sir. There was
But you
no
said there's
swelling,
no
but
anemia. But you said
no.
there's no anemia.
So there was no pallor visible, sir.
All right. So pallor is not there, but Platonychia is there. What does it
Yes.
mean?
Sir, in early cases of iron deficiency anemia, sir.
So Platonychia comes in early stage or it comes late stage. If somebody loses blood today, say there's a massive upper GI bleed or a lower GI bleed, there will not be any Platonychia. Platonychia usually will indicate a chronic deficiency of iron. However, we haven't got into the blood test report as yet, but you have till now said that there's no pallor, but there
No
was
pallor.
Platonychia.
Yes.
Okay. Dr. Somani, you have
Yeah.
any question to ask him?
Yeah. So, Dr. Amin, can we rule out tuberculosis with this history and examination?
Sir, I would still keep tuberculosis as a possibility in this patient, sir.
So, what is the how many patients with tuberculosis presents its PR bleed?
Sir, in ileocecal TB, in a minor subset of patient can present with PR plate. So the exact figure around.
So basically, I want to ask is whether PR bleed is more common in IBD, as in Crohn's disease, or tuberculosis.
Sir, it is more common in Crohn's disease as compared to tuberculosis.
More common in tuberculosis.
Crohn's disease as
Crohn's
compared
disease.
Crohn's disease as compared to tuberculosis.
Okay. And one thing you mentioned that she didn't allow you to do PR. So what were you expecting on PR, or what you were looking for in this patient?
Sir, I would have asked for. I wanted to look for any anal skin tag, a perianal fistula, or if there is a painful PR, or there is a fresh blood on PR examination, or if there is a hemorrhoid, external hemorrhoid, which is seen.
Rather than hemorrhoids, you were more looking for any perianal abscess, fistulas,
Perianal abscess, yes.
non-healing fissures, any. So that would lead you to more which diagnosis?
Sir, it will lead more towards the Crohn's disease if these features were present, sir.
Now, how many patients with ulcerative colitis have this perianal findings?
Sir, it is less likely with ulcerative colitis.
So you should have, I think, sir, infective colitis should have been ruled out by now. Okay. Only differential would have been inflammatory bowel disease, immunocompromised state to rule out, and tuberculosis.
Okay, let's move
And of
forward.
course, yes.
Sir, on investigation, sir, hemoglobin was 10.4. Her hematocrit was 33.4. Mean corpuscular volume was 81.4. Her total leukocyte count was 10,500. Platelets were 5 lakh 10,000. Peripheral smear showed mild poikilocytosis and hypochromia. Her ESR was 80 mm at the end of 1 hour, and CRP was 40 international unit. Her liver function test showed bilirubin of 0.4 gram per dl, AST 124, ALT of 112. Alkaline phosphatase were elevated to 426. Her GGTP was 513. Albumin was 2.9 gram per dl. Total proteins were 9 gram per dl, and INR was 1.2. So she had elevated alkaline phosphatase in GGTP with transaminosemia in her liver function test.
And platelet count is
Sorry,
high.
sir. Yes, sir.
Platelet count is high and there's mild anemia.
Mild anemia. Yes.
Okay.
Her viral markers for hepatitis B and C were negative, sir. Thyroid profile was normal. Serum calcium was low, but the corrected calcium was normal, sir. Serum IgG levels were normal. Serum copper oxidase activity was within the normal limits for females, sir. In autoimmune workup, ANA was weakly positive. Her asthma was positive, sir. AMA, ANC were negative, sir. She had vitamin D and vitamin B12 deficiency with with the iron deficiency as well, sir. TIBC was 535. Serum iron saturation was 4.5%. Sir, HIV was negative, sir. Her HIV was negative. I forgot to mention, sir. The HIV was negative, sir. On stool examination, 15 to 20 pus cells per high power field, sir. Occult blood was positive, sir. Her fecal calprotectin was more than 3000, sir. On colonoscopy, sir, there was the rectal mucosa and sigmoid colonic mucosa was normal, sir. Vascularity was seen in the there was no ulcers. Whereas in ascending colon and whereas in the transverse colon and ascending colon, there were mucosal ulceration with granularity and mucosal friability. Evidence of easy contact bleeding was seen, and there were no pseudopolyps, sir. So these features were consistent with ulcerative colitis.
So what is the scoring?
Sir, Mayo grade 2 score, sir. Endoscopic Mayo grade 2, sir.
Okay.
So
The first one is rectal sparing you have shown.
yes.
Huh?
Yes, sir.
So how do you explain rectal sparing in ulcerative colitis?
Yes.
Sir,
What
since
percentage of patients with ulcerative colitis there are rectal sparing?
sir,
Approximately.
patient who have got overlap with primary sclerosing cholangitis, patient who are partially treated, and pediatric ulcerative colitis patient will present with rectal sparing, sir.
What do you mean by partially treated?
Sir, those who were
Treated with
taking
what?
topical treatment.
So you should clarify that those who are taking enemas or topical preparation may have rectal sparing because it will produce healing in that area.
Was
So,
your patient treated?
No, sir. This was the index admission for
So how do you explain rectal sparing in this patient?
Sir, we are anticipating that this patient is having primary sclerosing cholangitis overlap, sir. In primary sclerosing cholangitis, it is the right-sided colon and which is more commonly involved, sir.
this is I'm not aware of it, Dr. Somani. Is it? I'm not updated on that.
So,
Is
sir,
it that
yes,
rectal
patient with
sparing is more common?
yes, UC with PSC rectal sparing is seen.
All right. Okay, carry on.
Sir,
So
sir,
what
we have a
are
lot
the
of questions on the chat box.
Yes,
So
you can
first
ask.
thing,
You can ask
yeah,
him. No problem.
yeah. So first question is, can we put lymphoma in the differential diagnosis?
Sir, lymphoma can be a differential diagnosis in this patient, but it is less common as compared to adenocarcinoma if we keep a malignancy as a differential.
So I would say lymphoma is possible. It's not impossible, but I would not keep it in differential diagnosis since it is very rare to present like this and very, very uncommon unless patient is known immunocompromised or HIV. Sir, we would like to have your comment.
Yeah, I agree. But for the examination point of view, I would have played safe by just talking about colonic malignancy and not committing an adenocarcinoma in my differential diagnosis. I think it will be safer from your examination point of view. Agreed that adenocarcinoma is much more common than lymphoma is. But to play safe, I think you could have avoided this question by just saying that you are thinking of colonic malignancies, which will include lymphoma as well as adenocarcinoma.
And why was fecal calprotectin done? Is it necessary in this patient?
So, sir, initially as a part of workup, we did fecal calprotectin because they were not initially willing for colonoscopy. We had to give them some evidence for undergoing colonoscopy. Patient was afraid of colonoscopy, so we did for this patient. We had to give them evidence of inflammation and prepare them for colonoscopy. Otherwise, it is not needed. It should not be a part of a routine workup in this patient.
So you can say that it will be helpful later on for the follow-up. You don't need to do colonoscopy again. You have baseline levels. You treat her. If she's clinically better, you can repeat the fecal calprotectin, and if the markers are normal or going drastically down, you can safely say that she is in remission. So that way, it is helpful.
I would support what Dr. Somani is saying, and I would not buy your excuse of saying that you did a fecal calprotectin to confirm and to show to the patient that she or he has some inflammation. I think as a doctor, somebody who is presenting with bleeding per rectum, you don't need to show a report of fecal calprotectin being high to perform a colonoscopy. That will doubt your possibility, your confidence of counseling your patient. So you don't have to show the patient a report of fecal calprotectin and then say that now that fecal calprotectin is high, I'll do a colonoscopy.
So fecal calprotectin will be high in any inflammation.
Yes,
it is not diagnostic of any inflammatory bowel disease. It is just a marker. It will be high in tuberculosis also, malignancy also, or any infection for that matter.
Yes, they were not
only differential diagnosis. Only where it can help is if you are thinking of irritable bowel syndrome.
Yes.
With irritable bowel syndrome with hemorrhoids as a cause for bleeding per rectum. There, fecal calprotectin may help, but I would agree with Dr. Somani that a baseline fecal calprotectin can help you in following these patients. All right.
And one last question. So it is seen on your image that rectal sparing is there. So someone is asking, can we put it as Crohn's colitis above ulcerative colitis?
Yes, sir. Crohn's colitis can be kept as a differential in this patient. But since there was a continuous involvement, there were no aphthous ulcers, and there was the features were more favoring endoscopic features were more favoring ulcerative colitis.
Ileocecal valve was normal, no?
Ileocecal valve was normal, sir.
Okay, and what was the extent of involvement? The right colon is involved or it's not involved?
Yes, sir. The ascending colon was involved, sir.
Okay.
Okay. Sir, we move forward.
Yes.
USG abdomen was done. It showed mild hepatomegaly with altered echo texture. There was normal hepatopetal flow in portal veins, and intra and extrahepatic biliary radicals were not dilated. However, RF scan showed a mean value of 2.27 meter per second, suggestive of moderate fibrosis. In view of the elevated alkaline phosphatase and GGTP, we did a MRCP of this patient, sir.
So, what did you say? RF value is 2.27.
Yes, sir.
So 2.27 you take as moderate fibrosis at your center?
Yes, sir.
Okay. At our center, we believe 2.27 means grade 4 fibrosis. But it's all right. I think their values are not very standardized for RF as yet, as compared to the usual FibroScan, EcoSense machine. Okay.
So we did a magnetic resonance cholangiopancreatography for this patient. In MRCP, there were intermittent areas of focal narrowing and dilatation seen in peripheral branches of right and left hepatic duct.
Can you show us that? Can you show us?
Sir, the bleeding appearance and
so bleeding show us with the arrow. Where are that?
Sir.
So this bleb which you are showing on the right side can be an end-on picture.
So this one, yes, sir.
This can be end-on picture, and
yes, sir.
Then I agree that on the left side, some of the radicals are showing irregularity.
Yes, sir.
Can you trace the cystic duct for me here?
Sir.
Can you trace the cystic duct?
Sir.
Where is it arising from?
So this is the cystic duct, sir.
Can you look at the left margin of
the insertion of cystic duct into the CBD?
Look at the left margin of so-called bile duct. I personally feel cystic duct is very low insertion.
Yes, very low insertion. Yes.
And it's coming from the left to the right.
Yes.
Yes, sir.
You agree, Dr. Somani?
Yes, absolutely, sir. Very low insertion.
So it's not just the right side which is the cystic duct. Even the left side of the hepatic duct or left side of the common bile duct is cystic duct. All right, but that's just a finding.
Yes. Then again, sir, mild focal narrowing was seen in the left hepatic duct and proximal common hepatic duct, sir. Common bile duct also showed focal area of narrowing in distal part with moderate narrowing in terminal ends. There was mild hepatomegaly with liver measuring 16.7 centimeter with mild atrophy of left lobe and hypertrophy of the right and the caudate lobe. GB was mildly distended and showed folds within. The imaging features were suggestive of primary sclerosing cholangitis involving extra and intrahepatic bile ducts. On colonic biopsy from transverse and ascending colon, their crypts were mildly dilated, crypts were distorted, and they were focal crypt loss. This area showed focal crypt loss. They were dilated crypts, and the crypt distortion is seen in these two slides. There was lamina propria showed lymphoplasmacytic infiltration. Large lymphoid aggregates were seen with few neutrophils and eosinophils. Occasional cryptitis was also seen. This area showed epithelial regeneration with few prominent nucleoli. Histological features were of active ulcerative colitis. There were no pseudopolyps. On diagnosis, ulcerative colitis involving transverse and ascending colon with Mayo score of 7. Primary sclerosing cholangitis involving extra and intrahepatic bile ducts without cholangitis with Amsterdam Oxford PSC score of 0.85. Moderate liver fibrosis and malnutrition with micro and micronutrient deficiency. Treatment: patient was started on triplet prednisolone orally 30 mg per day, mesalamine 2.4 gram.
Can I just ask you one question before you proceed to the treatment? Now, when there is a primary sclerosing cholangitis, can your RFE score will be showing falsely high?
Yes, sir. It can, sir.
Because see, there is an inflammatory process which is there inside the liver. And any inflammatory process will give an increased RFE score.
Yes,
so I think to say that there is a diffuse fibrosis in this case may be overreading the RFE score.
Okay, sir. Sir, the mild atrophy which was seen in the, sorry, sir. The mild atrophy which was seen on the MRI, sir, of the left lobe, sir. The left lobe and hypertrophy of the right and caudate lobe was also seen, sir. So, will that be any clue for the involvement of the liver?
It all depends on where all the sclerosing cholangitis changes are there, and that may cause disproportionate decrease in the size of the liver. So I think to draw a conclusion that this indicates cirrhosis of liver or fibrosis may be a little premature. Of course, the biopsy is also not showing you evidence of cirrhosis, isn't it?
Sir, biopsy has not been done.
Liver biopsy has been done?
Not
no,
done.
sir.
All right. So I think it may be overreading, but I am not ruling it out. I'm just trying to say that there are false high value of RFE because of many reasons. So can you tell me what are the other causes of false high RFE?
Sir, non-alcoholic fatty liver disease, autoimmune hepatitis, alcoholic hepatitis.
So any inflammatory, any hepatitis going on with raised transaminase, you should not make a diagnosis of fibrosis by RFE or by, for that matter, by fibroscan until the hepatitis process is controlled. Same happens with cholestasis. Any cholestasis can give rise to high increase in the RFE or EcoSense fibroscans values. All right. Okay.
Yes.
So once I would say once the patient stabilizes, you should do a liver biopsy in this patient. Also, our globulins levels were high and albumin was low. There was AG reversal. We don't know whether it is due to the hypoalbuminemia related to malnutrition or it is liver related. So I think we should do a liver biopsy later on. Go ahead.
Patient was started on oral prednisolone, mesalamine 2.4 gram twice a day, azathioprine. It was started after 1 week, and ursodeoxycholic acid 20 mg per kg per day in divided doses. Correction of vitamin D and B12 deficiency was done. Correction with oral supplements. Correction of iron deficiency was done with oral supplements. Nutritional counseling was done. Calories of 1600 to 1800 kilocalorie per day, and avoidance of lactose and non-absorbable carbohydrates in diet. Proteins of 1.5 gram per kg per day were advised to patient. Follow-up: patient showed a control of diarrhea with improvement in appetite. After 10 days of investigation, her hemoglobin was 10.3, MCV was 32.9, total leukocyte count was 10,000, platelet count of 540,000, alkaline phosphatase was 149, albumin was 4.1, and AST ELT has came down to 38 and 47. discussing,
Before
sir?
you go in, there are a number of
Just
questions in chat
wait,
box.
yeah.
Can you look at those chat box questions?
Yes, sir. So, first question we will take is how do you explain ASMA positive?
Sir, in primary sclerosing cholangitis, up to 20 to 25% patient can have ASMA positive. Although ANCA is more a positive ANCA is more common in primary sclerosing cholangitis. However, our patient didn't had ANCA positive. In few patients, there could be mild ANA positive as well in lower titers. ANA would be positive
Was
in lower.
serum IgG levels done?
Serum IgG levels were normal, sir. It was done, sir.
Is asked, so how do you explain B12 deficiency? I think it is purely nutrition patient.
Sir, in this patient, it was because of poor oral nutrition, B12 deficiency.
Was the patient vegetarian?
She was vegetarian, sir. She belonged to Christian family, but she was vegetarian, sir.
So, any other questions you want to ask?
No, it's all right. I think you have one more presentation. So until there's something important in his discussion, we can go on to the second presentation so that we can give equal time to the.
Just brush to your discussion 2 slides.
Yes. So the extraintestinal manifestation can be seen in up to 24% of patients before the onset of intestinal manifestation. IBD is seen concomitantly in 60 to 80% of cases of PSC, and majority are ulcerative colitis. However, only 2.4 to 5% patient of UC shows presence of PSC. Males and third to fourth decade of age are the most common population involved. Impact of either disease on one another. Impact of PSC on IBD, the colitis is clinically quiescent. It is predominantly a right-sided colitis. Evidence of backwash ileitis is seen. Higher frequency of pouchitis after ileoanal pouch anastomosis following total proctocolectomy. If associated with CD, they present as ileocolitis. Course of ulcerative colitis worsens after liver transplant is done for primary sclerosing cholangitis. During the immunosuppressive therapy for liver transplant, approximately 26.4% patient develop a de novo ulcerative colitis, and 37.5% of patient show acute flare-up. Tacrolimus is associated with increased rates of flare-up, and there is an increased risk of colorectal dysplasia and cancer in this subset of patients. IBD on PSC. PSC may be diagnosed even after proctocolectomy in UC. Its clinical course is independent of the management of UC. Increased prevalence of small duct PSC is seen in Crohn's disease as compared to ulcerative colitis. This was shown by a review by Ford. However, Barberio showed that a review by Ford showed that large duct PSC is common in both. However, small duct PSC is slightly more common in Crohn's disease patient. There is an increased rate and earlier age of occurrence of cholangiocarcinoma in concurrent UC patient. There is a higher rate of liver transplant in this patient and higher rates of death. Implication on treatment. According to an article published by Syed et al., up to 1/3 of patients required biologic. Small bowel involvement was more common in these patients. The use of biologic resulted in clinical remission in over 3/4 of patients, but endoscopic remission was achieved only in half of the patients. Use of biologics and immunomodulator was not associated with higher rates of cholangitis in these groups of patients. Another article published in Gastroenterology showed they studied use of vedolizumab in IBD PSC overlap. They concluded that a clear-cut benefit on liver biochemical parameter is not observed when this cohort was treated with vedolizumab. However, a 20% a subset of patients showed a 20% drop in alkaline phosphatase from the baseline. Those with liver cirrhosis and high baseline alkaline phosphatase has a better alkaline phosphatase response. Thank you.
Two quick comments here, Dr. Amin. One is that when you quote any figure, try to find out some literature from India, because Indian data is available. There are a couple of studies which have looked at extraintestinal manifestation in IBD from India. Yes. One which I remember is Dr. Rawal published something on this not too back, I think 2016 or 17 sometime. So yes, please look at the Indian literature. And the second is the vedolizumab is a gut-specific biologics.
Yes. Sir.
So how should it work in PSC?
Sir, they they thought that the increased epithelial barrier function will help in reducing the bacterial translocation, and which can lead to inflammation in the bile ducts, which can prevent the inflammation in bile duct. The paradigm of their study was that the increased poor epithelial barrier function leads to the bacterial translocation and cause of injury to the bile duct. So vedolizumab, by improving the epithelial barrier function, will control the PSC parameters in this patient.
But in general, vedolizumab is not used for any extraintestinal manifestations.
No, sir. No, sir. Yes.
All right. So should we move on to the second presentation?
Yes, sir. I think we'll take other questions
only
and
15
later
minutes
on.
left.
Yes, yes. So we'll move on to next. So next presentation is by Dr. Nupur Mehta. She is our third year resident, and she'll be speaking. She'll be reviewing a journal article on extraintestinal manifestations of IBD. Go ahead, Nupur.
Good evening, everyone. Is my slide visible?
Yes.
Yes. So we'll start. Mine is a journal article review on extraintestinal manifestations of inflammatory bowel disease, current concepts, treatment, and implications for disease management. This was published in the October 2021 edition of Gastroenterology Journal. So definition: an inflammatory pathology in a patient with IBD that is located outside the gut and for which the pathogenesis is either dependent on extension / translocation of immune responses from the intestine, or is an independent inflammatory event perpetuated by IBD, or that shares a common environmental or genetic predisposition with IBD. Extraintestinal manifestations occur in 6 to 47% patients of IBD, and up to 24% patients present have manifestations before appearance of intestinal symptoms. Extraintestinal manifestations mostly affect joint, skin, or eyes, but can also affect other organs such as liver, lung, and pancreas. This is the figure which shows the extraintestinal manifestations. So we start from the eye. So there is uveitis, episcleritis, scleritis, conjunctivitis. In the oral cavity, there is aphthous stomatitis, periodontitis, cheilitis, granulomatosa. In the lung, there is pneumonitis. There is axial arthritis affecting the spine and central skeletal system. Then there is in the liver, there is primary sclerosing cholangitis and autoimmune hepatitis. In the skin, there is erythema nodosum, pyoderma gangrenosum, and Sweet syndrome. Then there is altered pancreatic function, acute or chronic pancreatitis, autoimmune pancreatitis. There is peripheral arthritis and enthesitis, and there is also increased propensity of thromboembolism. So this is the table which shows the extraintestinal manifestations with the prevalence rate. So this is the same. There is a PSC, autoimmune pancreatitis, autoimmune hepatitis, with a prevalence of 5%. Mucocutaneous, which includes erythema nodosum, pyoderma gangrenosum, oral aphthous ulcer, Sweet syndrome, and orofacial granulomatosis. The prevalence is approximately 15%. Musculoskeletal includes IBD related arthritis, peripheral arthritis, axial arthritis, enthesitis, with a frequency of 10 to 20%. Ocular manifestations include episcleritis, scleritis, and anterior uveitis, with a prevalence of 5 to 12%. And there is a pneumonitis, which is very rare, and vascular complications include increased predisposition to cardiovascular disease, thromboembolic phenomenon, and portal vein thrombosis. So this is pie chart showing the prevalence of extraintestinal manifestations is between 6 to 47% patients. Approximately 20% of all patients in IBD have 2 extraintestinal manifestations, and more than 10% patients have 3 or more different extraintestinal manifestations. Pathophysiology: it has been assumed that factors related for the pathogenesis of extraintestinal manifestations are similar or the same as for intestinal inflammation. Factors responsible for development of extraintestinal manifestations of IBD are genetic factors, environmental factors, activation of immune system, and role of microbiota. So there are various genes which have been found out after genome-wide association studies, and various extraintestinal manifestations have various different genes which are implicated in the pathophysiology. For example, for sacroiliitis and uveitis, there is NOD2 and CARD15. PSC, there is a variety of genes which is SOCS1, JAK2, STAT3, tyrosine kinase 2, and etc. For Pioderma Gangrenosum, it is IL8, RA, PRDM1, USP, TIMP3. For ankylosing spondylitis, it is IL23 receptor. For erythema nodosum, PDGER4, ITGAL, SOC S5, CD207. Environmental factor, smoking has been excessively studied for extraintestinal manifestation correlation. Patients with CD who smoke are more likely to present with extraintestinal manifestations compared to non-smokers. Smoking is associated with a 10% higher incidence of skin and joint extraintestinal manifestations. Smoking cessation appears to have positive effect on the prevalence. Interestingly, smokers are protected from the onset of UC, and former smoking is a known risk factor for development of UC. Extraintestinal manifestation can arise from cross-reactivity of antigen-specific immune responses against intestinal antigens at non-intestinal sites. A molecular mimicry between gut microbiota antigens and non-microbial epitopes present on cells in the organs affected by extraintestinal manifestations is seen as a potential reason for a cross-reactivity of T cell clones and immune cross-reactivity. Leaky intestinal barrier, microbiota, lipopolysaccharides, bacterial antigens, or metabolites could be translocated from the gut to extraintestinal site or can cause systemic inflammatory responses. A dysbiosis could lead to an activation of intestinal immune cell populations that finally migrate to other organs. So coming to musculoskeletal extraintestinal manifestations, they are most common, seen in approximately 46% patients. Their prevalence decreases with increasing age. So there is arthralgia without arthritis, which is seen in 5 to 16% patients. There is ankylosing spondylitis, inflammatory back pain with imaging evidence of sacroiliitis, seen in 1 to 12% patients. Isolated sacroiliitis, sacroiliac joint erosions or sclerosis on imaging, seen in 16 to 46%. Inflammatory back pain, back stiffness without radiological findings, seen in approximately 17 to 22%. Dactylitis, swelling of entire digit, seen in 2 to 5%. Enthesitis, tendon, ligament, or joint capsule insertion pain, seen in 6 to 54% patients. So, peripheral arthritis is diagnosed using musculoskeletal ultrasound and MRI resonance imaging. Findings include signs of arthritis, enthesitis, tenosynovitis, and bursitis. Serological diagnostic tests like rheumatoid factor and anti-CCP are generally negative. Axial arthritis and spondyloarthropathy occurs concomitantly with peripheral involvement. MRI findings include inflammation, bone marrow edema, bony erosions. Sacroiliitis is usually bilateral. There are two types, symptomatic and asymptomatic. Asymptomatic is seen in 50% patients, most commonly with Crohn's disease. Symptomatic sacroiliitis is characterized by low back and buttock pain at rest that improves with mobility. So the therapy most commonly used for peripheral arthritis is a treatment of intestinal inflammation, COX-2 inhibitors, corticosteroids short term, sulfasalazine especially in UC, methotrexate, and anti-TNF antibodies. For axial arthritis, anti-TNF antibodies. Skin manifestations, prevalence is 5 to 15%. Erythema nodosum, characterized by tender red or violet raised subcutaneous nodules of 1 to 5 centimeter in diameter, seen on extensor surfaces of the lower extremities, usually on anterior tibial area, heals without scarring. Treatment is sufficient treatment of intestinal inflammation. Corticosteroids initially 40 to 60 milligram per day, followed by tapering, or anti-TNF antibodies. Pioderma gangrenosum begins as an erythematous pustule or nodule, rapidly developing into deep ulcers with irregular violaceous edges and purulent material in the ulcer ground, which is sterile on culture. Patients have severe colonic involvement. Treatment includes oral steroids 40 to 60 milligram per day with tapering, cyclosporin with a target level of 150 to 300 nanogram per ml, tacrolimus with a target level of 10 to 15 nanogram per ml, anti-TNF antibodies infliximab and adalimumab. Topical tacrolimus can be used with a 0.1% ointment 2 times per day. So these are the images showing erythema nodosum and Pioderma gangrenosum. Sweet syndrome, also known as acute febrile neutrophilic dermatosis, skin lesions, tender or papulosquamous exanthema or nodules located on arms, legs, trunks, hands, or face of varying sizes. It can also be seen as a side effect of azathioprine. Treatment includes control of intestinal inflammation, topical or systemic steroids, and immunomodulators. Metastatic Crohn's disease. Skin histology shows granulomas and can occur anywhere on the integumentum. Genital or vulvovaginal lesions might be most disabling, severely impacting quality of life. There is no correlation with intestinal disease activity. Treatment is topical or systemic corticosteroids, immunomodulators, and anti-TNF agents. Oral pathologies. Prevalence is 5 to 50%. These are of two types, aphthous stomatitis and periodontitis. More common in pediatric and Crohn's disease patients. Aphthous stomatitis can be treated with topical steroids and anesthetics. Most systemic treatments like corticosteroids and anti-TNF antibodies are also successful. Periodontitis is a chronic inflammatory condition causing destruction of the anchoring bone and soft tissue. Symptoms are gingival inflammation, swelling, and bleeding, leading to loss of teeth. Smokers are at higher risk for periodontitis. A rare oral manifestation is orofacial granulomatosis or Melkerson-Rosenthal syndrome, also known as cheilitis granulomatosa. The treatment is systemic steroids and immunosuppression. So this is the image showing the rare extraintestinal manifestations. The first image is of Sweet syndrome. The second is showing the lipogranulomatous inflammation of the lip. The C is the metastatic Crohn's disease involving the vulvovaginal region. This is the nodular variety of skin lesions seen in Crohn's disease in the perianal region. This is a rare retroauricular Pioderma Gangrenosum lesion. And this image shows bronchiectasis and pneumonitis seen in a patient with ulcerative colitis which has manifested after colectomy. Ocular extraintestinal manifestations. So they are episcleritis, scleritis, and anterior uveitis. Less common are retinal vasculitis, papillitis, corneal infiltrates, myositis, scleromalacia perforans, and optic neuritis. More common in Crohn's disease. Episcleritis is the inflammation of the episclera, the tissue that covers the sclera. Scleritis occurs in less than 1% cases, and if untreated can cause permanent visual loss. So scleritis, the types of scleritis are anterior, which can be diffuse, nodular, or necrotizing with or without inflammation, and posterior. Treatment is control of intestinal inflammation, topical and oral steroids, and infliximab in severe cases. Uveitis is the inflammation of uveal tract, the middle layer of the eye, which includes iris, ciliary body, and choroid. Uveitis in patients with IBD is initially treated with corticosteroid eye drops. If not successful, systemic steroids, immunosuppression, or anti-TNF agents can be used. So this image shows the first image is of episcleritis and the second image is of scleritis. Hepatobiliary extraintestinal manifestations, primary sclerosing cholangitis.
I think if I can, this we already discussed, so maybe you can skip that because we have only a minute or two left.
Okay,
so we
sir.
already discussed in the previous presentation.
Yes, sir. So I'll move to hepatitis. So the hepatitis involvement is of three types: autoimmune hepatitis, IgG4 related cholangitis, and granulomatous hepatitis. The other causes which we have to look for is drug induced due to thiopurines, methotrexate, anti-TNF antibodies, and JAK inhibitors. The other cause could be reactivation of hepatitis B, viral hepatitis due to cytomegalovirus, Epstein-Barr virus, and others. Arterial extraintestinal manifestation. These patients are at increased risk of acute myocardial infarction, heart failure, and cerebrovascular insults. Pathophysiology include increased systemic inflammation and endothelial dysfunction. Risk reduction is very important in patients with IBD. Thromboembolic events. Patients with IBD are at increased risk of venous thromboembolic events, include deep vein thrombosis, planktonic venous thromboembolism, and lung embolism. The pathophysiology is endothelial dysfunction, platelet activation, and impaired fibrinolysis. Risk of VT complications increases with severity of inflammation and is highest amongst hospitalized patients with acute severe colitis. Pancreatitis is a rare manifestation. There is acute idiopathic pancreatitis, more commonly seen with Crohn's disease. Acute pancreatitis as an extraintestinal manifestation has to be discriminated from pancreatitis caused by IBD specific medications such as azathioprine, or in rare cases 5-aminosalicylic acid. Duodenal involvement of Crohn's disease can be seen in patients presenting with acute pancreatitis. Type 2 autoimmune pancreatitis is found more frequently in patients with IBD than in the general population. There is an antibody against exocrine pancreatic tissue which has been associated with asymptomatic exocrine dysfunction. Here, amylase lipase are elevated, but they can also be elevated in patients who have severe active colonic disease. Pneumonitis is a rare manifestation, wherein ILD is more commonly seen in ulcerative colitis and granulomatous lung disease is seen in Crohn's disease. So the take-home message is extraintestinal manifestation in patients with IBD contributes significantly to the burden of disease. Discrimination of drug adverse effects, that is pancreatitis due to azathioprine or 5-aminosalicylic acid therapy, skin affections due to anti-TNF therapy, or lung disease due to methotrexate therapy and EIMs can be particularly difficult in patients, however, needs to be attempted to optimize treatment. Specific anti-inflammatory symptomatic treatments and therapies in multidisciplinary team approach are necessary to address EIMs adequately and to improve quality of life of our patients. Okay, thank you.
I think it's a good review which has been done in this article, and you presented it well. Dr. Somani, any final comments before we wind up?
So this is very, very common topic, and I think IBD is rampantly increasing in India. We see almost daily new cases of ulcerative colitis more than Crohn's disease. I'm sure you will concur with me on that, sir.
Yes, I think, but we are realizing that Crohn's disease is possibly increasing.
We still see UC more. Yes.
Yeah.
And off late on the cases where, sir, Crohn's disease versus tuberculosis, we are not sure what it is. We are erring more on the side of Crohn's disease, and we are seeing that most of them are Crohn's disease rather than tuberculosis off late.
I agree with you that possibly we are seeing a lot of Crohn's disease, but then in a given case, it may be always difficult to differentiate the two. And if we have any doubt, then we usually would treat with antitubercular drug for 2 months rather than starting with steroids and considering biologics.
Yes, that's what we do.
And see the response after 2 months and then decide what to do.
So any more questions you want to ask?
No, it's all right. I think we have already crossed about 3 minutes.
So everyone has one question, sir, not related to this, but they are worried about the format of the practical exams. If you can answer that.
Nobody knows. So let's wait.
Okay.
Nobody knows as yet. We would know. I think theory exam is in June, and then the practical exam. I think the last time the practical exam partly was done was all in the conventional method. So we are moving more towards conventional method rather than OSCE based exam. But I would not commit anything as of now. So should we close down, Mr. Singh?
Yes, thank you very much, Dr. Siddiqui and Dr. Noor for the presentation, and thank you very much, Dr. Vaibhav Somani and Dr. Mahesh Goenka for joining us. And thank you, trainees, for joining us.
Thank you.